what do you? So shall we pass along and never stir assailants? Were it not better that I did shoot me, all points like a man, and in my heart lie there what hidden women's fear their will. We'll have a swashing and a morsel outside, as many other mannish cowards have, that do outface it with their semblances. What shall I call you now, art a man? I'll have no worse a name than Jove's own king, and therefore look you call me Ganymede. But what will you be called?
As long as humans have had the capacity for desire, we have desired all kinds of impossibilities. We want to turn lead into gold. We want to live forever. We want to turn back time. What interesting myth doesn't feature an alchemist, king, or hero trying to defy the limitations imposed by nature? But not all of us crave the same things. Some desires are near universal. Others are so rare that they strike the common person as incomprehensible. Yet our collective imaginations are vast, and few dreams are truly novel. So when trans activists say trans people existed throughout history, they're sort of right. Cross-sex desire, typified by discontent with one's sex and the quest to transform into the opposite one, exists in the historical record. When activists say trans people, though, what exactly do they mean? This is a question I've been wrestling with as I watch videos, read articles, and engage in discussions online. Gender, trans, gender identity, gender dysphoria. These terms are often thrown around as if they are synonymous, but it has become clear to me that they are not. My goal here today is to put into words all the thoughts and hypotheses I've formed in the process of watching this space. Some points that I make are grounded in research done by proper parties. Others are purely speculative. So rather than take it as a scientific argument, I ask that you approach this from an intuition and observation standpoint. The result of seeing, reading, and listening, and trying to tie all those pieces together into a statement declaring my understanding of the issue. Firstly, though, we must disambiguate. The manner in which some of these terms are used in diagnostic guidelines, psychiatric care, and activism leads me to believe that we are approaching them in the wrong way. Primarily, I think we are incorrect in treating gender dysphoria as a distinct condition that always necessitates transition, when in fact it acts more like a symptom that can be comorbid with many different conditions, and only sometimes attaches to individuals with genuine cross-sex desire. In other words, gender dysphoria is only part of the bigger picture. Thus, I want to divide matters into two things. Gender dysphoria is a symptom that can be associated with a variety of psychiatric conditions: body dysmorphia, OCD, borderline personality disorder, narcissistic personality disorder, depression, anxiety, trauma, and so on. Gender dysphoria primarily encompasses the negative emotions and despair associated with physical features of one's natal sex. Cross-sex desire, the other component, has subsets. Those with gender identity disorder, which gives them the intense, compulsive desire to become the opposite sex, and those who are trans, who actually believe they are the opposite sex in some manner. To delineate clearly, imagine a person with gender dysphoria who does not desire to be the opposite sex, nor identifies as the opposite sex. A person with gender identity disorder who wants to be the opposite sex, but feels no strong despair about their natal sex and does not actually identify as the opposite sex. A person who identifies as the opposite sex but does not have gender dysphoria. What can cause this array of feelings about one's sex? What are the roots of despair, desiring, and identifying? Dysphoria and cross-sex desire are not well understood, but they are driven by a variety of factors. This does not make these traits unique. All psychiatric conditions are like this. The symptoms manifest differently from person to person, and their causes can come from a variety of places. In fact, how psychiatric illness is categorized and treated continues to be a raging debate to this day, because we still only have a rudimentary understanding of the mechanisms underlying these conditions. We've developed therapies that seem to work for many of them, but we don't know exactly why they work or how they work. See antidepressant medications as a concrete example of this. Psychiatric medicine is something of a quantum mechanic. We can use it, but without a clear view of the inner workings. So my claim should not come as a surprise. The traits we see within this umbrella of individuals are more often than not comorbid, but they can, on unusual occasions, travel alone. Having only one of these aspects rarely leads to a lifetime of gender identity confusion, and there are those who may possess many of them at once but do not struggle with their gender identity. Hence, I think they serve best as explanatory factors, not determinative ones. The constellation of assorted traits can be broadly broken down into two areas: biological and social. I'm not going to spend a lot of time differentiating the two, though, as in all things, there's crossover and gray areas one might dispute. Ultimately, though, it's a way of thinking about internal and external factors and how they might interact. Biological factors include some of the obvious points, such as experiencing symptoms of gender dysphoria and possible cross-sex brain similarities, or at the very least, brain structural differences from their same-sex peer. Autoimmune disorders are a potential factor. For instance, many trans individuals have diabetes. Genetic factors would also be at play, as well as more complex biological contributors, such as the mind-body connection, a process that centers on the brain but also manifests through the nervous system as a whole. Anything that impacts the brain really could be of note here. Brain damage, trauma, chemical imbalances, mental illness, neurological degradation, disruption of perception. All of these could impact a person's ability to accept their body and sex. It is also possible, though I've not seen research in this area, that environmental pollutants, lifestyle, or diet can have a downstream effect on the biology of a cross-sex identifier. Social factors encompass many, nearly innumerable things. The culture in which a person grows up will impact how they understand gender roles and their sex. It will also endow on them interpretive models through which they decide the significance and meaning of their internal feelings. More individualistic cultures versus communal cultures will have different ways of thinking about personal identity. At a more local level, people are impacted by their immediate environment, whether rural or urban, liberal or conservative, healthy or toxic, upper class or lower class, high stress or low stress. Their community and family life shape their perceptions of sex, gender, and themselves. And any dysfunction within those circles of influence can lead to bodily distress or identity crises. Peer groups and subcultures add to the mix by offering individuals advice, moral instruction, values, and new ways of thinking that may break them away from broader social norms. There are entire communities online dedicated to friend groups commiserating about their gender, and the push to validate, celebrate, and redefine boundaries means that anyone entering them with comorbidities will be sure to go through a subtle and sometimes not subtle recruitment process. The combination of biological and social factors means we can have a whole host of arrangements. There are a substantial amount of trans people without gender dysphoria. There are a substantial amount of trans people with no contributing biological factors. There are trans people without cross-sex brain similarity. There are non-trans people who have gender dysphoria. There are non-trans people who have cross-sex brain similarity but no gender dysphoria. And there are many non-trans people who have gender dysphoria and cross-sex brain similarity but no conscious identification as the other sex. If all this is so, then what is trans? Gender dysphoria and gender identity disorder are fairly easily categorized. The idea that a person might loathe their own sex and desire to be the other is straightforward and easy to imagine. But trans, actually identifying as the other sex, what is that really? The fact is, none of the biological or social factors are entirely predictive of trans identification. Even having gender dysphoria as a child has a low standard of predictability for their state as adults. Some studies stating persistence as low as 20 to 40%. Cross-sex brain similarity accounts for some gender identification, but other studies suggest this has more to do with same-sex attraction. Many non-trans people will experience transient, temporary feelings of dysphoria about their sex, especially during puberty. Many trans people will have histories of abuse, neglect, or trauma, but other trans people grow up in pampered homes with few problems to speak of. So what unifies people who identify as the opposite sex? Certainly nothing material. Nothing psychological or psychiatric, nothing environmental nor biological. They don't even seem to show the same symptoms. It is this notion of gender identity, which at its center is a purely metaphysical belief. To be trans is not to possess any particular set of traits. As trans activists will tell you, anyone can be trans and valid, but it is to make a declaration of faith, an assertion about reality that cannot be verified, but only felt. This is where I must split hairs. Trans people exist, just as Christians exist, and communists exist, homeopathic practitioners exist. Trans describes a person who possesses a constellation of traits driving them to believe or declare they are the other sex. These feelings are not faked for attention or some kind of deceit. They are genuinely expressed. But wanting is a different matter from being. Just because an individual wants to be the opposite sex and feels like it's true, and those feelings are expressed in earnest with such strength that they cause the person to spare should you contradict them, does not make them true. We do not give beliefs more credence as they are more powerfully believed, though such zeal might cause us to take the position more seriously. Beliefs still must be evaluated. This is where some discussions derail. Trans activists sometimes erroneously believe their ideological opponents don't believe in gender dysphoria or gender identity disorder, or even that trans people exist. But an atheist believes that religions exist. They believe that people believe in God. They believe in theists. Where they do not align is the metaphysical claim of truth. Is God real? And so for the trans opponent, the claim they must evaluate is gender identity a concrete thing that is hosted in the body or psyche, a fixed reality that must be obeyed? Or is it instead a product of a strong desire, an idea so focused and powerful that it feels true even when it is not? Some say that trans is an umbrella term, and I agree. If trans does not have any shared traits, but is simply a belief lived out by a variety of interested parties, then you can start to understand the sorts of people who are drawn in and how they might relate to each other. Here I have divided types into female and male parallels. To avoid confusion, female here should be understood to refer to the biological category, the typical XX phenotype. Male refers to the biological category as well, typical XY phenotype. Trans-identified female is a biological female that identifies as trans. Same for trans-identified male. As these are broad group labels, of course, some individuals will share similarities with multiple groups. In comparing my typology to others in the field, though, I think mine hits a lot of the same notes and accurately describes some different patterns that are visible in trans communities. You could also compare some of the groups to personality disorder clusters, especially to clusters B and C. This typology does not deal with non-binary or agender, which I believe can sometimes appear in these groups, but nonetheless works a little differently. So starting with the female typology. Trans-identified females are overall more neurotic, they are more interested in people than things, they are less prone to suicide attempts, they are less likely to succeed, they are low in violence and aggression, but they can be high in social manipulation, and they also tend to be fairly low in sexual libido. They are also more averse to extreme risk-taking. The first group is the neurotic type. The neurotic type is high anxiety. They might have a history of abuse, either emotional or sexual, or neglect, a family history of mental illness or dysfunction. Many of them you'll find have an eating disorder or a pattern of self-harm in their past or present. They might have puberty-induced or trauma-induced dysmorphia, and they are highly influenced by others, often socially isolated or showing symptoms of autism. Usually they are androphilic, that is, they are attracted to men. A common thread with the neurotic type is having no or little to no history of gender non-conforming behavior in their past. Medical transition for these females usually yields poor results. It does not resolve their anxiety or their self-harm behaviors, and it gives no resolution to their mental illness. Suicide attempts are frequent but often unsuccessful and female typical. The next type is the histrionic type. These are typified by desperate need for attention and validation. They have no history of gender nonconforming behavior before they took performative actions later in their life. Body dysmorphia, related to an unstable sense of internal identity, probably due to either a borderline personality or narcissism. They often transition for social acceptance and for group dynamics. Other conditions they have: OCD, narcissism. They often suffer from low self-esteem, but their needs are the priority of the group. They tend to take leadership roles in groups, memorize the group's controlling platitudes, monitor others' behavior, and recruit. These are the activist type. Typically, they are androphilic or bisexual. Commonly, they will use suicide as a threat to coerce others or play the victim. They will often collect marginalized statuses and change identities with some frequency. The paraphilic type, sometimes known as fujoshi or autoandrophiles. These are an exceptionally rare type of female that usually through porn consumption become obsessed with a fetishized version of gay males to the point of desiring to become one. These females tend to be autistic, antisocial, sexually inexperienced, and prone to delusional patterns of thinking. They tend to be disgusted by the thought of being directly involved in sexual activity. They prefer to be a voyeur who projects onto third-party scenarios. You can find these in anime, fanfiction, or other highly colorful, fantastic, or sexual fandoms. They're not likely to pursue medical transition. If they do, they will go off and on hormones, perhaps get top surgery, but they overall prefer to stick to social transitioning. The masculinized type. These are what we traditionally think of trans men. They express early onset gender nonconforming behavior, such as cross-dressing, cross-sex behavior and play, cross-sex socialization, and a persistent expression of belief that they are internally the opposite sex. They are usually gynophilic, meaning they are attracted to women. They have distress and discomfort with their body. They usually live comfortably through their pubertal years and young adulthood as lesbians, then medically transition as adults. Very few will seek phalloplasty or bottom surgery. This group is the least likely to have mental illness concerns, though they will have severe depression about unwanted sexual traits. Suicidality, though, is pretty rare. Generally, they respond well to transition, but also blend well with butch lesbian scenes, whether or not they medically transition. Now for the male subtypes. Trans-identified males are overall less neurotic. They are more interested in things than people. They have high libido. They are low in social adeptness, high in risk-taking behavior, more aggressive, more pathological, and more suicidal. The neurotic type is what we think of as the classic sissy boy or failed male. Sometimes they are femboys. These are intensely shy and sexually detached. They might be homosexual, straight, or bisexual. Regardless, they struggle to fit in with other males. They are highly emotional. They may connect with females more than males. However, they do not exhibit classically feminine behaviors or thinking. They may have a history of abuse or neglect or family dysfunction. Many of them are autistic. This group will often have an interest in video games, computers, programming, or other highly technical fields. Cross-dressing is used as a comfort tool to reduce stress. Self-harm and eating disorders are also common here. They may get drawn in by pornography or role-play fantasies. They may seek out transition, but usually stick to estrogen, drawn by its soothing effects. They will often have ruminating, dark thoughts about suicide. Next, we have the histrionic type. This is essentially an outgoing gay male, a sort of drag queen aesthetic. They have no history of body dysmorphia. They may have experimented with cross-dressing as a child or acted flamboyantly, but they have the fashion sense and skill in using makeup and social media to construct their appearance. They are often borderline personality or narcissistic. They constantly need to be the center of attention and need validation. They will mirror or adopt behaviors of women they know or previous sexual partners. They are adept in controlling controlling others via emotional manipulation. They have a poor sense of boundaries. They may be inappropriately sexual or aggressive with others. They are politically active, sometimes activist. They tend to rise and fall, experience the height of mania and the low of depression. Like their female parallels, they will play the victim, but unlike their female parallels, they are very likely to be involved in alcohol and drug abuse. The paraphilic type, known as the autogynephile. The paraphilic type will have no history of body dysmorphia or gender non-conforming behavior from childhood, but they nonetheless have a strong desire to become a woman. These desires often arise in adulthood. Often, it will be an adult male married to a woman with children who suddenly awakens to these desires. Their distress leads to thoughts of suicide. They will often be happy with the physical results of transition, but the costs can be a burden on their relationships, family, or partners. As they are usually gynephiles, they will want female partners, but they may struggle to find willing lesbians, as they will not behave in a convincingly feminine way. Homosexual autogynephiles face similar difficulties. They lack self-consciousness and self-awareness. For example, they may be convinced that they pass when they don't. They may wear unflattering clothing. Pornographic consumption is central to their identity development, but they have conflicting feelings about sexual desire, both enjoying and pursuing sexual pleasure, but feeling disgust or detachment from their genitals. Finally, we have the feminized type. This male has early onset gender non-conforming behavior, such as cross-dressing, cross-sex behavior in play, cross-sex socialization, and a persistent belief that they are internally the opposite sex. They are typically androphilic, meaning that they are attracted to men. A large portion of these young males will go through puberty and resolve into their natal sex as effeminate homosexual adults, but the remainder will persist in lifelong cross-sex desire and obsession. This group has a high suicidality rate, high distress about sex characteristics, sometimes leading to attempted self-castration. They have strong, sometimes desperate desire to medically transition. They are also big risk takers. They abuse drugs, alcohol, and other substances. They often engage in sex work. Some feminized type males have a pattern of homelessness and unemployment. They suffer from delusional or magical thinking, sometimes coinciding with schizoid or psychotic behavioral problems, other times exhibited in strong religious or spiritual belief systems. However, they tend to fare better with medical transition than the other types, probably due to legitimate biological, neurological reasons. After this long list of hypotheses and explanations, you might ask, well, even if this were all true, what does it matter? What does it matter why people identify as another gender, and how those people might fit into different groups? Does that change anything about the discussion? The main implication, I think, is for how we approach the treatment question. It is undeniable that when a person is mentally ill or experiencing severe psychological distress, we ought to offer treatment to ameliorate it. However, up to this point, trans activists have acted as though medical transition is both a life-saving procedure and the only option for all trans people, and to treat, as they would say, a condition that is not even a mental illness. This would only make sense if gender dysphoria was a deadly condition all to itself, but of course it isn't. It's a symptom many people experience at different times of their life. Furthermore, we know that not all trans-identified people have gender dysphoria, so to suggest that they too deserve the same kinds of treatment should unsettle any sense of certainty here. We need to avoid trapping ourselves into a one-size-fits-all treatment plan, when those typologies may be radically different, require different care, and have different outcomes. Some may benefit from non-invasive psychotherapy to treat underlying conditions like depression and anxiety. Some may benefit from libidinal treatments or lifestyle changes. Yet others may be in such extreme distress that hormone replacement therapy and surgeries could be on the table. Even in studies about the treatment of gender incongruence, there's not a lot of understanding of what series of steps actually works or why. Treatment is highly individualized and varies country to country. And what we find, especially among medical detransitioners, are subsets of transitioners who were poor candidates, probably easily identified by their neurotic typology, but overlooked because they were lumped in as trans. Selling social transition, hormones and surgery is easy. They require no complex introspection or conversations. Increasingly, they are handed over with little more than a self-declaration of intent. But if we aren't investigating other, less invasive means for decreasing distress, then there will be costs. One such cost, of course, is to those who are diagnosed but not differentiated for good outcomes. Even if you're correctly diagnosed with gender dysphoria, if it's rooted in trauma, depression, or anxiety, then surgery is possibly going to make matters worse. This cost is steep for those who regret transitioning. Loss of fertility, loss of bodily fidelity, loss of a normal life. And it's true that as gatekeeping evaporates and more people transition, this is going to happen more. However, sometimes I'm afraid we overstate this as the worst cost of the matter. The reality is, most people who transition report feeling happy with the results. Even if detransition is somewhere around 8%, a number that's at the higher end of possibilities, that cohort is not where most costs of medical transition occur. To think more clearly about this, we have to ask an important question. How do we judge the efficacy and ethics of a medical treatment? How do we balance medical quality of life with psychological happiness and satisfaction? Should we permit people to pursue procedures and drugs that will trigger disease, dysfunction, and even death if the psychological effects are sufficiently positive? If it was the case that every trans person was on death's door, ready to end their life, our calculations might be different, but suicide rates are vastly overstated. Being trans is not a death sentence, so we must think through a bigger picture. Often, I hear people say, so long as they're adults and they consent, and they're happy with the results, they should be free to pursue it. A liberal view, and one that sounds fair to be sure. In the world of medical ethics, though, there are far more questions to be asked, such as, state of mind. Is the patient in a clear state of mind? Do they understand both the present situation and their possible future after having the procedure? Are they able to separate reality from fantasy? Are they desperate? And how does that affect how they measure risk? Invasiveness. How invasive is the procedure? Are there less invasive procedures that can offer equal or close to equal results? How significant is the difference in benefits as procedures get progressively more invasive? Risk versus benefit. Are there more risks than benefits? Are the risks worse than any net benefit? How likely is the procedure to induce complications, disease, illness, injury, or death? Projected outcomes. How successful is the procedure in other patients? What are the goals of the procedure and are they measurable? Is there a consistent standard for what a good outcome entails? Are there both physical and psychological components being considered? Continued needs. Does the procedure make the patient dependent on a drug for the rest of their life? Will they need continued follow-up indefinitely? Will the procedure likely necessitate future procedures as complications and side effects accrue? How many surgeries will be needed? How many doctor's visits? And lifetime drug prescriptions? Maintenance of function. How many natural functions will be affected? Will any be lost? Will the patient lose control of their fertility, bowels, blood sugar, immune system, sexual satisfaction? Longevity. How long will the effect of the procedure last? Will it need to be redressed in the future? How many weeks, months, or years before it needs to be redone? Lifespan. What is the impact of the procedure on the individual's lifespan? How will the individual age? What will happen when they are too old to care for themselves? Will certain side effects appear in the later years? Accommodations. How many accommodations will the procedure impose on other people in their life, on the public, on strangers, on medical professionals? Relationships. Will the procedure disrupt or harm their relationships with their spouse or significant other, their children, friends, parents, coworkers? Will it lead them to form harmful relationships? Consent is barely a fraction of these concerns. Satisfaction is only a bare minimum item on the list. Dosing an addict with heroin might be consensual and give the patient great satisfaction, but that is not enough to justify it, when a whole host of other costs must be accounted for. This means for any individual, we must be more frank and honest about the risks and benefits in medical transition, and not treat it as a panacea for all gender-related ills. There's a lot of hand-wringing about conversion therapy whenever the matter of psychological treatment is brought up. This is understandable. After all, if trans is a belief system, and psychological treatment is used to take someone out of that belief system, then it is really a conversion. We should, though, take care to consider what the goals of treatment should be. If treatment is merely there to satisfy a patient's whims and make them happy, that would create some rather problematic implications for the treatment of other conditions. If the treatment is meant to reduce the distress of gender dysphoria, then doing this via talk therapy versus hormone therapy shouldn't matter. Distress is distress, and reducing it by the least invasive means is appropriate. If the treatment is meant to reduce cross-sex desire, then we can debate the more interesting point if it's moral or ethical to dictate what someone desires, keeping in mind that some desires are destructive or unhealthy. If the treatment were to try to persuade a trans person that they are not the opposite sex, then there is a good argument that that's inappropriate. Trans is not a medical or psychiatric condition, but a belief. It may be an incorrect belief, or even delusional, but only as much as any religious claim could be. Where such treatment may be justified, however, is if the belief has taken over the patient's life and become an obsession, a parallel to hyper-religiosity. If the belief drives them to estrange their friends and family and pursue endless, unnecessary medical procedures, then this ought to be addressed in a compassionate way. For me, then, that means the best path forward seems to not be to challenge trans identification, but instead to focus on the least invasive means possible toward resolving distress and destructive desire. Challenge negative feelings about one's sex and sexual features. Challenge the notion that becoming the opposite sex will solve all their problems. Challenge their belief in the necessity of hormones and surgeries that will have lifelong impacts on their health outcomes. If a patient is left trans, believing they are really the opposite sex on the inside, but have overcome dysphoria and decided not to use hormones and surgery, this is the ideal, least invasive outcome. As we move towards a culture more accepting of cross-sex behavior and dress, there should be ample opportunities to live out the social desire without compromising the body. Only in cases where the distress is so extreme that less invasive measures don't work should we really encourage individuals to medicalize. Alternatively, if there are less invasive medical procedures that have negligible negative effects, those too can be available to those who are capable of assessing their remaining risks. What is clear from the literature ultimately is that whatever series of steps such people take in a progression of treatment, emotional support is key. And emotional support, by the way, does not mean unconditional support or unquestioning support. It means putting aside shame and scorn. It means talking and listening. It means being a human, not a conveyor belt or a doormat.